very quick bit of background. There will always be C. diff infections, okay? If you think it's going to disappear and we're never going to have any, think again. It's here. It's ubiquitous organism, found everywhere in the environment, soil, water, carried on systematically, and we know that there certainly are carriage rates of up to 7% in the general population, so we're never going to get rid of it. C. diff infections will occur outside the healthcare environment under the right conditions, and it'll be interesting over the next couple of years. Russell was talking a little earlier about some of the monitoring, which is going to be hospital onset, community onset, where they're healthcare acquired, and those very small numbers which are truly community onset, community acquired. So over the next couple of years, we're going to see a different way of actually looking at some of the data to help us try and focus our business. And I think one of the problems we're sort of seeing at the moment is the hospital onset is probably increasing, even though they come in the community. And I think we're just very savvy at picking them up and getting them allocated to the community. And I think that's why we truly have to sort of work together. So 2016-17 objectives. So this could be a really quick talk. I could just say they were the same as last year, because that's what they are. I'll talk you through some of the history of how we've got there. They're based on requiring continuous improvement, and it's about organisations with higher rates to try and do more than those with sort of lower rates. And the bit that has changed in the last sort of couple of years is actually how commissioners can exercise discretion on imposing sanctions for breach of an objective. But it should only, and I stress this, where those C. diffs were associated with lapses in care. And that's what I'm going to focus on for quite a bit of the thing, which is the whole of this lapse in care and how it is or isn't done very well in organisations. So history objectives, so we wind the clock back to sort of 2008. I'm sure there's about 3 or 4 Daily Mail readers within the NHS, because they normally occasionally tell fibs about us. But the headlines were, C. diff superbug kills 1 patient in British hospitals sort of every hour. And actually, I'm really pleased that headline came up, because actually that really started to get people focusing on what we needed to do. And sometimes you need headlines like this to really make a difference. And you may or may not be aware that actually 1 in 5 patients who get C. diff is dead within 28 days. My data from my organisation, where we followed it up, is 1 in 3 die within 3 months. This is why C. diff is still really, really important, okay? It ends lives of some of our patients prematurely, so it's still very important despite how good we've been. So prior to 2014-15, then there was a 50,000 fine per CDI over the preset objectives. And it worked. Whatever you think about it, it worked. We saw a 74% reduction, which is staggering. And 80% of these were hospital onset and healthcare associated. You can see how it's sort of the numbers have come down. Then in 2014, we were encouraging people to see if it was linked to a lapse in care. And only cases associated with lapse in care should be considered for inclusion in calculations for financial sanctions. There are some people, and I partly agree with them, who think the lapse in care is almost a get-out-of-jail card free, and it's probably led to some of the slight increases. And maybe we might pick that up in some of the questions a bit later on. But they had highlighted that some organisations have already got their C. diff levels to an irreducible minimum level. And actually having all these sanctions, per se, based on numbers rather than lapses in care is probably not helpful. So they came up with a formula for setting the objectives, and you can see it listed on there, telling a difference between non-teaching and teaching trusts. There are some trusts who've tried to be reassigned into the teaching category rather than non-teaching, so it gives them a higher amount. And anybody who was actually at November 2013 below the current Hallgrand basically had 1 less than the number that was on there. And if you were worse than the cohort, you basically use your current annual rate minus cohort reduction. And we reduced the fines from 50,000 to 10,000 per case over objective. Because actually, unless the money for the fines was saying, actually, you need to invest it back into healthcare, looking after those patients, it won't improve the care of patients. So if you say, like my organisation got fined, I think £7 million 1 year, you want that money to actually be focused on improving the care of our patients. The other big change was rule changes. All patients had to be tested and reported because there was an awful lot of gaming. And on one of the reports on fingertips, it lets you look at the number of toxin tests that are being done, because I still think there's some gaming being played out there. You may have your own views. So this is the lapse in care checklist. It basically goes through whether the patient had diarrhea or admission and what the risk factors were, whether there were delays in using Bristol stool chart or isolation. Was the sampling following the guidance? Where had the patient been for the previous sort of 3 months? What sort of contact did they come in? Was it recurrence? Were they treated correctly initially? What other things are they on? Proton pump inhibitors? Was it appropriate or not? What antimicrobial therapy have they had for the last 3 months? Were they following guidelines? Were they being de-escalated? What about the treatment of CDI? Were they following the guidance? Did they actually assess for severity or not? How's your environment? Is it clean? What about in the organisation? What's your staffing like? What's your training like in communication? And then, have you actually been focusing on optimising diarrhea in your organisation? So if you go and look at Leicester, is there anyone from Leicester here? No. They've had a real effort on focusing on sort of diarrhea management. And a lot of their antibiotics they've been choosing have been those that don't cause diarrhea. And then preventability, which is looking at relapses. So this is a graph on what the rates are looking at. And in 2014-15, it went up by 6%. And you can see it was mainly within non-trusts. I think there has been a little bit about testing anybody who comes through the door with diarrhea. And that's why we want to see whether it's associated to healthcare or not. And this last year that's just finished, we saw actually a decrease again. So we're still higher than the 2013-14 sort of data sort of on there. And because of that, the objectives remain the same to allow organisations with higher rates to make realistic improvements because there was that growth. Okay, so what's happening in reality with lapses in care? Well, this is a questionnaire that went out across London, and it was sent to all of the London CCGs about their local processes and outcomes with lapses in care assessment for the year 2014-15. And this was the data that came back in February on there. And so you got it from most of the CCGs. There were a few in the south that hadn't replied. And there were 16 acute trusts represented in the surveys. And again, there's something about the south not answering. So 60% of acute trusts actually reported C. diff numbers above their threshold. And then you can see that only 14% of the 671 cases agreed as related to a lapse in care. And they had a range between 0 and 50. Now, perhaps in the questions later we can talk about this. I know in our organisation it's much higher. We've got an objective for the ones we take there to get down to 50%. Because I think we're brutally honest for anything we've done sort of wrong. 6 out of 16, so 37% of trusts had agreement that it had no lapses in care. I don't believe that. I don't think there are ever things whereby, or there are very few, where there is no lapses in care. And then, and no trust had a financial penalty imposed on there. And one CCG actually reported they hadn't followed the lapse in care process, but they were doing it for the following year. Okay, so that was that bit. What about community cases? So you can see most of the CCGs responded. What did it show? So out of the 30 to 26, 2 only looked at cases related to serious incidents. 5 only looked at cases related to community inpatient facilities. 6 said they had no process in place. 3 described the acute process only with no reference to community. 1 said they're not notified of any cases. 2 said they described difficulties related to information government, and 2 described a comprehensive process, that's good, and 2 said they're gathering broader insights and they're coming up with something. So that's pretty poor, I think, what was going in London. And it'd be interesting to see what's happening over the north of England. Now, the final bit I'll describe is just potentially a good model to follow. And within Leeds, we've actually adopted this model currently. So this is from West Hampshire, Clinical Commission Group. It's called the SHIP region. There are 8 CCGs, 7 acute trusts, 2 community trusts looking at population of almost 2 million, and you can see the rates of C. diff that were there. They have an appeals panel. All cases are heard within the collaborative, so everybody sort of sits in. It has a single submission using local paperwork and a checklist. They hope to have an equitable and consistent judgment on all cases, because it's by the same people, and there will be transparency about the decision-making in numbers, so it's not sort of an enclosed room type of things. And they take a degree of expertise from around the sort of the local sort of area. And then you can work your way down the algorithm that they've sort of come up with for sort of lapses in care. So there you go. You can see all the people who sit around the panel. So CCG, quality managers, infection prevention control, public health, medicines management, Public Health England, NHS England, deputy director from CCG, and then there are specialist people with knowledge, so a consultant pharmacist, a provider, and a microbiologist on there. So that's the set panel that they have. And this is just what they're sort of doing. So all the providers, including the senior nurse and medical dips, are invited to stay for the whole panel, not just their own cases. And for me, this is the really important thing, is they're also expected to bring along a summary of the lapse in care cases so that everyone's aware of what you can learn for where there have been lapses, not just trying to see where you're claiming there has been no lapses sort of on there. And you could see in this particular thing, they came up with 58% of those submitted actually had were agreed as having no lapse. So they put 24 in, and 14 were supported, 10 were thrown out because they'd identified lapse in care. So in summary then, the objectives in 2016-17 were the same as 2015 and 16. Since 2007, there'd been a 74% reduction in C. diff, but certainly it's plateaued over the last 2 years as we're probably getting to almost an irreducible level. Hospital onset CDI cases dropped markedly, 84%, and community onset cases with less than a degree, 59%. And I think that's because we're a bit more savvy about sort of testing, but nearly most of them are healthcare acquired. I'm worried about the wide variation in lapses of care implementation, and I think perhaps there needs to be a little bit of look about what happens between various CCGs. And I think a collaborative review model might actually allow better learning and consistency approach. And so the model I've shown you from the SHIP region in Hampshire is quite a good model to copy. And the future is very much about a local antimicrobial resistance healthcare-acquired infection approach that we will have to do. And I would say PHE, so Public Health England fingertips, which will be updated on a monthly basis, is a good way for you to look at your own data, and it will start to become much more live as well as retrospective data. And you should use that in all of the meetings that you end up sort of going to compare, to benchmark yourself against others and your own continual improvement. Thank you very much.